Hello, everyone. My name is Lonny Yarmus. I am an associate professor of medicine and oncology at Johns Hopkins Hospital in the United States. It's a pleasure to be here, and thanks to Dr. Felix Firth for the outstanding earlier presentation. I'll be talking to you about our approach to the diagnostics in lung cancer, and specifically our all-in-one approach. Here are my disclosures listed here. Directly pertinent to this talk is clinical trial funding and consulting with Olympus and Baron Medical. So to start off, I just want to talk about conceptually bronchoscopy today and tomorrow. So bronchoscopy, as many of you know, has really come a tremendously long way over the past few decades. With novel interventions and advancements in the technological space. Most notably, EBUS, introduced about almost 20 years ago now, and navigational bronchoscopy. And with a lot of these advancements has become sort of the ultimate goal of an all-in-one diagnostic and therapeutic bronchoscopic intervention where we can take patients, stage them, diagnose them, provide genetic assessments and molecular analysis, and then eventually move towards treatment with negative margins, all in a single procedure that is safe. We've accomplished the first three here, and there are movements now to look towards treatment modalities, both in Europe and the United States. So we're not quite there yet, but we're really moving rapidly forward, and things have advanced significantly even over the past 5 years. What I'd like to do today is really go through an overview of the importance of lung cancer diagnostics and staging, some of the current evidence base, and then really concentrate on peripheral bronchoscopy as we approach it in our practice with procedural workflow, planning, registration, navigational aspects, different types of scope technologies and the instruments that we use, and then spend the remaining time talking about prospective evidence-based approaches that exist or are ongoing, and then an open forum with Dr. Hirth and myself for questions. I'll start first with a case. We have an 81-year-old male with a solitary pulmonary nodule who presented to our clinic about 5 or 6 years ago now with a 0.8 centimeter solitary nodule, who underwent repeat CT scanning 1 year later, and the nodule grew to 1.1 centimeters. Patient had a history of severe chronic obstructive pulmonary disease, was on home oxygen, multivessel coronary disease, and was considered high risk, presented at a multidisciplinary tumor board and was thought to be a non-surgical candidate. So the group recommendations at this point were for PET scan imaging, followed by EBUS for staging, and then an option to discuss with the patient consideration of an electromagnetic navigational approach for diagnosis of the nodule, or consideration of radiotherapy without tissue diagnosis. I'll come back to this at the end of the talk, but I just wanted to present this as a common scenario that I think that many of us face, and the challenges that go with it. So the dilemma here is many of the nodules, like the case we just saw, can potentially represent a curable form of lung cancer, but the flip side is it also may be benign, leading to unnecessary procedures and surgeries with resultant morbidities and cost. Here's some data from Mike Gould, published in the Blue Journal back in 2015, estimating that in 2016, there were about 4.8 million CT scans performed in the US in that year. 63% of them, or 3.2 million, showed no evidence of a pulmonary nodule, but 1.6 million, which is a large number, identified a nodule in 30% of that total population. What I think is most pertinent here is out of that 1.6 million nodules identified annually, 1.5 million of them are false positive. So about 100,000 were cancers. What's important here to recognize is if we were to just take out every nodule, you can easily see that we'd be removing a lot of benign nodules with an unnecessary and unacceptable morbidity and cost. So we need minimally invasive techniques like peripheral bronchoscopic advancements to allow us to get to these nodules safely and diagnose not only malignant disease, but work towards improvements on diagnosing benign disease as well to avoid unnecessary surgical interventions. The flip of this is that those that have lung cancer, we all know lung cancer accounts for 13% of all cancer diagnostics and 25% of all cancer deaths. Non-small cell lung cancer still accounts for approximately 85% of all lung cancers, and approximately 25% of non-small cell lung cancers that present in the United States present with at least stage 3 disease. So moving towards trying to get earlier diagnostics, again, with peripheral bronchoscopic techniques is an important aspect of our care to merge with lung cancer screening and try and diagnose these patients much earlier so their outcomes are significantly improved. So how do we do this? We know that there are multiple ways to try and diagnose or at least identify nodules. Radiographic screening and CT screening is the primary intervention. So we have CT scans, we have PET scans, and they can obviously identify abnormalities, but they do not do a great job of positively identifying them as malignancy. So we use these tools for clinical staging, but they can markedly differ from invasive or tissue staging. And I think that's well illustrated here, showing that CT scans alone have a 50 to 70% sensitivity for malignancy and a 60 to 86% specificity. PET scans a little bit better, 50 to 85 sensitivity, but a specificity in the 74 to 93% range. So again, valuable tools, but not sensitive or specific enough to make a confirmatory diagnosis, which results in the need for tissue. The remaining aspects of the table show outcomes for sensitivity and specificity for mediastinoscopy, EBUS, EUS, and a growing combination of EUS and EBUS. And you can see the specificity of the tissue diagnostics are all 100%, but I draw attention once again to the sensitivity here, showing that previously mediastinoscopy was considered the gold standard, and now due to a lot of evidence base over the past several decades now, we've really shown that EBUS is the gold standard with a sensitivity of EBUS and EUS of almost 90% and a slight advantage to combining those two modalities. So with this, the use of invasive staging before making any treatment decisions is critical to obtain the most accurate assessment for appropriate therapy and prognosis for patients. If we were to rely just on PET or CT imaging, mediastinal lymph nodes are going to be falsely overstaged by PET or CT in approximately 19% of patients and understaged in approximately 13%, both numbers unacceptable for adequate care, once again highlighting the need for tissue. Here is an overview of the general pathways for local regional lymph node staging with non-small cell. As you can see, it all starts with CT and PET scan. And then it splits here based on lymph node size, if the mediastinal nodes are suspicious or not. If they are suspicious, the guideline pathways across the globe at this point are for tissue confirmation with EBUS or EUS first. But I'll draw attention to the left side here when the lymph nodes are not suspicious. And this is a very common scenario if we go by older guidelines suggesting a radiographic finding of a lymph node greater than a centimeter is suspicious. We'll often see smaller lymph nodes. And some of these older guidelines would take us down a pathway if there's a clinical N0 peripheral tumor or tumors less than 2 centimeters with no suspicion of mediastinal involvement, that patient can go directly to resection. Due to some increasing growing data that I'll present some today here, we've seen that we have traditionally been underdiagnosing those lymph nodes. And that's why you see that little dashed line here, which is now a growing movement for essentially EBUS for everybody with a lymph node, with a pulmonary nodule. And it is now our general practice at Johns Hopkins, where every patient who undergoes a peripheral bronchoscopy for a solitary nodule will undergo an EBUS first during that same procedure. And I'll share some data behind that as well. Most of those treatment paradigms and diagnostic paradigm differences that I've discussed really have to do with the burden of occult nodal disease, which is a radiographically negative mediastinum or hilum on CT or PET, which then ends up with pathologic evidence of involvement within those lymph nodes. So what is still relatively unknown is how do we identify those patients, which patients should need pathologic nodal assessments, and can EBUS detect these occult nodal diseases? And then more importantly, or I guess as important, what's that clinical consequence of occult nodal disease as well? If we identify a patient with a 1 centimeter nodule who then has a N2 or N3 node, and that patient were to have undergone primary surgical resection, we know they're going to have poorer outcomes because they have stage 3 disease. The N1 patients who could be SBRT candidates could be limited by some of this, limiting peripheral nodule biopsies, and sublobar resection candidates all fall under that N1 candidacy. So identifying those different aspects of nodal involvement remains important for treatment. This was really nicely shown in an article by Neil Navani, published in Chest in 2019, looking at inaccurate clinical staging and how it leads to incorrect diagnosis and suboptimal patient outcomes. This was a meta-analysis looking at 698 patients with non-small cell undergoing surgery and radiation. The patients had poorer overall survival in those who were clinically understaged. I think not surprising, but incredibly important to highlight in an evidence-based fashion. And the patients who were clinically overstaged, or those in whom clinical and pathologic TNM staging agreed. You can see here in a very nice Kaplan-Meier curve here, the red line showing clinical understaging. So those patients who perhaps did not undergo primary EBUS or a full staging and underwent primary surgical resection, then born out to have a higher stage disease, had a worse survival. Roberto Casal at MD Anderson had a nice paper in 2019 in ERJ looking at occult nodal disease in clinical T1N0 patients. So these are patients who on radiographic imaging were deemed to be T1N0, underwent surgical resection. There were 596 patients resected. 83% of those were N0 on final pathologic staging, but 9%, 56 patients had N1 disease, 47 patients had N2 disease, and in this cohort, no patients had N3 disease. One of the factors presented here were central tumors were associated with the presence of a higher degree of occult nodal disease. We recently completed a study with Olympus and Varon called the All-in-One study, which I'll talk about. In this study, we had 150 patients prospectively who underwent electromagnetic navigational bronchoscopy with the Varon Olympus system. All of these patients were clinical T1N0, and in an early subset analysis that was presented earlier, 58 patients who were clinical T1N0 with a mean nodule size of 1.8 underwent EBUS followed by EMN. 8 out of 58 of those patients, or 14%, were upstaged. So essentially prospectively validating Dr. Casal's data with EBUS literature. Interestingly, most of the numbers were pretty much spot on. So 86% N0, 7% N1, and 7% N2. So again, this is a nice early prospective validation of the prior data, highlighting the importance of early EBUS, even in patients with clinical T1N0 staging. So with that context, what procedure should be used for the diagnosis of solitary pulmonary nodule? Well, we know the tools we have. We have bronchoscopy, we have CT-guided transthoracic needle biopsy, and we have surgical biopsies. This is just a table of complications from the lung screening, the NLST, the National Lung Screening Trial, published in the New England Journal back in 2011, which really paved the way for lung cancer screening. And I just highlight here at least one complication aspect of the table. showing that bronchoscopy overall had a 9% complication rate, needle biopsy 21%, and surgery 32%. So as we advance technologic improvements with peripheral bronchoscopy, it affords yet another great opportunity to utilize the safety of a minimally invasive bronchoscopic approach and combine that with some of these newer advancements to limit complications in these patients. This was really first nicely shown in a large multi-centered prospective registry called the Acquire Registry, which was run by Dr. David Ost at MD Anderson through the American College of Chest Physicians. Initially, this was a 15-center prospective registry where we looked at consecutive patients undergoing biopsy for peripheral lesions. Out of the 581 patients from 15 centers, 53.7 were diagnostic and a very low 2.2% complication rate, showing some center-specific yield ranges from 33 to 73%. What I really want to highlight here is there are differences in all the different technologies. This data is now old, right? This is 2016. And some of the newer advancing technologies like Varin, Olympus, EMN, and some of the robotic technologies were not in existence at that time. So we hope these yields will continue to increase. But again, the overall yields here are fairly decent with a 53% yield in these small nodules. And again, highlighting the importance of that very low complication rate of 2.2%. But there's clearly need for increasing advancements in peripheral technological therapeutics, shown here, I think, by a study conducted by Dr. Nicole Tanner at MUSC in a multi-centered fashion. This was a standard bronchoscopy with fluoroscopy versus the thin bronchoscope with radial EBUS study. Multi-centered prospective randomized controlled trial of almost 200 patients with an average lesion size of 31.2 millimeters. This was conducted at 5 high-volume academic sites in the United States. And as we look at a prospective randomized controlled trial, I think one of the important highlights here are that we continue to have challenges. So despite the high volume expert nature of some of these centers, bronchoscopy was only diagnostic overall at 44%, with radial EBUS being significantly superior to fluoroscopy alone, so 49% versus 30%. And what we concluded here was that bronchoscopy with or without a thin scope and radial EBUS overall still has relatively poor yields. Radial EBUS has a benefit, but future work should be focused on improvements in technique and advances in technology to ensure a higher likelihood of obtaining a tissue diagnosis. This, I think, highlights again that need for new advancements like electromagnetic navigational approaches. So if we look at the former state of EMN versus standard CT-guided percutaneous sampling, I'll highlight some aspects here. Overall, this was a nice comparative retrospective cohort study done at the Cleveland Clinic. And what they showed here was that a CT-guided biopsy for peripheral nodules had an 86% diagnostic rate. Navigational bronchoscopy, lower, 66%, which was statistically significant. But I'll highlight below in table 4, again, that's safety data. So any pneumothorax was only seen in 6% of patients with ENB guided sampling, but 43% of CT guided sampling, and highlighting the need for us to take advantage of those safety parameters. So with that in mind, can we do better, or should we just have patients undergo a TTNA? And certainly in some contexts, this TTNA have their role, but with the earlier data that I shared showing that EBUS has a significant benefit here, patients now, in our opinion, should be undergoing an EBUS as part of their workup for a solitary pulmonary nodule in the right context and right risk portfolio. So if that is being done, it is an advantageous time to utilize peripheral bronchoscopy. So we can combine the ability to stage and diagnose in a single procedure and limit multiple anesthetic encounters to decrease cost, increase safety, and limit healthcare encounters. So with that concept, we were first introduced to the Varian Olympus system for electromagnetic navigation back in 2015 and conducted an early pilot study, which was single center, approaching things as I discussed earlier, where every patient with a solitary nodule with no evidence of nodal involvement underwent an EBUS followed by a bronchoscopy with EMN, followed by a spin perc, which is the Varian Olympus electromagnetic navigation percutaneous system, which I'll talk about. We looked at safety and feasibility as primary outcomes, and then yield and adequacy. Here's just an overall flow diagram of that study and the general approach that we are now using on a daily basis, where patients undergo linear EBUS. We use rows in our bronchoscopic suites. So we have cytologic feedback. If that is positive, we collect enough tissue for molecular markers and stop. If that is non-diagnostic, we move on and do our Varian Olympus bronchoscopy. Again, positive, stop. If negative or non-diagnostic, we will then advance on to a EM-guided percutaneous biopsy referred as spin perc, and then the procedure is complete. This again allows us to now accomplish all procedures needed in a single setting. So patients do not have to go from a non-diagnostic bronchoscopy to a CT-guided biopsy, because they went from a non-diagnostic bronchoscopy to a electromagnetic guided percutaneous approach, all on the same encounter. And here's that data from the pilot, which was published back in 2016. Again, a combined approach. All nodules were less than, obviously, 3 centimeters. So they're nodules, 1 to 3. They were all clinical N0. All patients underwent a multidisciplinary review and had an a priori less than 10% estimated probability of a bronchoscopic diagnosis based on current platforms before introducing EMN. 24 patients in the study. There was a 21% pneumothorax rate with only 8% requiring chest tubes. All patients, I'll highlight, had EBUS, navigational bronchoscopy, and an EMN TTNA in this procedure in order to validate that approach and allow us for comparative yields, which are shown here, with EBUS alone being 21%. Once again, highlighting that earlier data, all of these patients were deemed clinical N0, yet 21% of them had nodal disease, showing again the importance of EBUS up front. ENB alone, 33% in these small peripheral lesions, and then combining EMN TTNA, 83%. And then interestingly, in this all-in-one philosophy, if we start combining these approaches and model them out as we would do with that algorithm I shared using rows, if patients had an ENB that was non-diagnostic and then moved on to an EMN TTNA, it was 87%. Or if all these were done, that projected yield for this pilot was 92%. So again, showing the importance of this data to highlight the fact that this can be done safely, and this can be done in a reasonable time. So introducing spin perc was only 18.3 minutes, performing that additional aspect of the procedure, and the total procedure time from EBUS scope in to spin perc needle out in this pilot was 72.5 minutes. We then looked more broadly, as this was an introductory pilot, and looked at the safety and diagnostic performance of pulmonologists performing spin perc. This was a multi-centered registry study looking at 129 EM-guided TTNA procedures at 7 academic and 3 community sites. And it was indeed a feasible procedure and performed in all cases. With an overall pneumothorax rate similar to the pilot of 22.5%. An overall complication rate of 22.5%, overall pneumothorax rate 17.8%, with a 12% pneumothorax rate requiring a chest tube, which were primarily small bore pigtail catheters. So this study, again, also showed that EMN-TTNA yield increased and helped to increase in a substantive fashion, with increasing from 74 to 83.5% with the addition of EM bronchoscopy and TTNA. They were safe and feasible in the hands of pulmonologists, at least in the United States. Many of the CT-guided biopsies are performed by our interventional radiology colleagues, so this was a change in general practice, but it did once again highlight the need for prospective trials to validate these findings, which I'm happy to report we have done with the support of Varian and Olympus. We performed a multi-centered prospective trial of EMN and EMN-TTNA, referred to as the all-in-one trial, which was a single-arm prospective multi-centered study of 8 academic and community sites to evaluate as a primary outcome diagnostic yield for EMN bronchoscopy and TTNA, with both a core radiology and pathology lab to validate findings, and a 1-year pathologic and radiologic follow-up. This study is complete, and the data is being formally cleaned as we speak, and we hope to present it at an upcoming meeting. As things continue to advance, we need more advancements as we're able to better reach into the periphery. Olympus has really led the way with radial EBUS as the only real-time sampling technique that we have. And there are now movements in the United States and abroad using radial EBUS and peripheral EBUS to look at real-time sampling techniques. Here's one example of a prototype we have published in Respiration back in 2019, looking at a combined hybrid technique with needle and peripheral radial ultrasound to allow for, excuse me, real-time sampling. And these technologies will continue to advance and hopefully be available in multiple platforms soon. In addition, we have tremendous improvements in the instruments being used. Here are some examples utilizing the Varian Olympus EMN system. These needle, brushes, extended working channels, and forceps are all tracked, meaning there is a sensor at the tip of them, which provides us, in our opinion, a significant advantage with electromagnetic navigational guidance, because the instruments do not have to be removed, or the tracking instruments don't have to be removed, and sampling can be done as soon as nodules are localized. Olympus, again, is really leading the way with EBUS, with new data and an exciting new smaller EBUS scope. So here are some images here just comparing. In slide segment A, you can see the traditional convex EBUS scope versus the newer scope, which is smaller, has a different angulation at the tip, as you can see in segment B. And then if you look at C and D, there's improved flexion with the instruments provided in the working channel to allow for better access, specifically moving over to the right, allowing these scopes to now be put up into the right upper lobe and more distally into the lower lobe bronchus. Moving towards, again, ideally, better diagnostics in the central lung zone to help account for some of those concerns with occult nodal disease in the more central lesions in the lung. Similar to that, smaller is better for, we think, for EBUS. We also think it's better for peripheral bronchoscopy, and the smaller our scopes can be, the smaller or the further out we can reach into the periphery. Here's a recent study of a manuscript now currently under review, where we used a small scope to approach in cadaveric models out into the periphery and look at different distances from lesions. So we looked at distances between 0 to 1 centimeter and less than 1 centimeter, 0 to 1, and 1 to 2 and greater than 2, and the impact on our ability to accurately hit these lesions either as a central target hit, shown to the panels on the left, an overall target hit anywhere within the lesion, or a clear miss. We did this in cadaveric studies and validated in a blinded fashion with cone beam CT. And you can see in the table on the right, our target hit rates are significantly improved as we move closer and closer to the lesion and utilize tools such as radial EBUS. So to finish up, I just want to get back briefly to our case, our 81-year-old male with a solitary pulmonary nodule, who the nodule grew to 1.1 centimeters. We discussed the consideration of navigational bronchoscopy with the patient, and the patient was interested in obtaining a tissue diagnosis rather than considering treatment without a firm diagnosis. We actually enrolled this patient as one of the first patients in the all-in-one pilot study. So he underwent a combined EBUS staging and EMN bronchoscopy and spin perk. The results were interesting. So this patient who was deemed high risk had an EBUS with TBNA of 7, 4R, and 11R, which were all non-diagnostic or negative. The patient then underwent an electromagnetic bronchoscopy with radial EBUS, and we were unable to identify that lesion because there was no central airway into that lesion to help us definitively identify it and puncture the nodule. So we then converted in that same procedural interface to spin perk, and the patient did not suffer a pneumothorax, but we were able to obtain a diagnosis, which was a benign chondroma. So this, I thought, was an interesting highlight case to bring back to the importance of improved diagnostics, not only for malignant disease, for benign disease. So this is a high-risk patient who was not a surgical candidate, who we just, basically helped avoid unnecessary radiation, which was a risk given some early interstitial lung disease shown here as well. So in summary, EBUS remains a critically important procedure that should be used regardless of clinical staging in patients undergoing bronchoscopy. Peripheral navigation's made a tremendous large improvement with electromagnetic navigational bronchoscopy, catheter advancements, and sampling tools. TTNA is not going away. It remains an important approach, but as peripheral bronchoscopy techniques improve, its utility will likely decrease. There are, and hopefully will continue to be, multiple ongoing prospective clinical trials to help with further development and guidance. I'm going to stop here and thank you. To follow this, we have a question and answer session with myself and Dr. Hirth. And I want to thank you again for listening. Here's my contact information. If anybody has any questions, my email is at the bottom. And thank you again. Have a great night.